Chapter 15 is our last chapter in the textbook, and we will focus on fecal analysis. There are many reasons to analyze feces. We want to detect bleeding in the gastrointestinal tract. It assists in the differential diagnosis of diarrhea. It will help diagnose steatorrhea, malabsorption, and maldigestion diseases or disorders. It may detect hepatic, biliary, and pancreatic diseases. And it also is important in identifying bacterial, viral, or parasitic infestations. About 9,000 milliliters of liquid enters the intestines each day, and 150 ml exits in about 100 to 200 grams of feces, which is normally passed each day. The small intestine is where the magic happens. This is where digestion breaks down the food into soluble, absorbable nutrients. The large intestine has the waste products from this digestion process, and in the large intestine, the absorption of water, sodium, and chloride occurs so that the stool becomes formed. Diarrhea develops if water absorption is inhibited or inadequate for the time allowed for absorption, so it's moving through faster. Constipation results from stationary bowel contents or decreased intestinal motility. There are nerve endings in your intestines that move food or the feces forward, and if this is inhibited or not occurring, then constipation can happen. We're going to talk about 3 classifications of diarrhea and causes of each. Diarrhea is increased volume, liquidity, and frequency of bowel movements compared with an individual's normal pattern. I'm sure each of you at some time in your life has had a bout of diarrhea. It's not pleasant, and you definitely want to be close to a restroom. The first type we're going to talk about is secretory, and this is an increased solute secretions by the intestine draws water and electrolytes into the intestine, so we have an excess of fluids. This could be due to enterotoxin-producing organisms or damage to the mucosa due to drugs or disease. Osmotic is very similar, but it has different causes. It increased osmotically active solutes to draw water and electrolytes into the intestine. So one has to do with secretions and one has to do with osmosis, where we go from higher concentration to a lesser concentration. This could be due to maldigestion or malabsorption. The last type is intestinal hypermotility, and this causes abdominal distension, which stimulates motility. There are nerve endings, again, in your intestines that will cause feces or fecal matter to move forward. And if these are working overtime and working too fast, then there's not time for the water that's in there to be absorbed out. This could be due to laxatives, stress, drugs, or other diarrheas. This decreases the time available for absorption, and it can occur alone or with secretory or osmotic diarrhea. Tests can be performed to differentiate secretory versus osmotic diarrhea. These both have osmotically active solutes, but the source differs. So to differentiate, you need to measure the fecal osmolality, which is sodium and potassium. And osmolality is the amount of dissolved substances in a fluid, usually. And we usually do this on urine, and we can do this on serum, but sometimes it is done on fecal matter. So you calculate the fecal osmolality from the sodium and potassium and compare with the actual osmolality. If the difference is greater than 20 milliosmoles per kilogram, it is osmotic. If it's less than, it is secretory. There's 2 types of diarrhea, acute and chronic. In acute diarrhea, this has a sudden onset and usually resolves in less than 1 to 2 weeks. However, it may persist for up to 4 weeks. The majority of cases of acute diarrheas are resulting from toxin ingestion or infection with a variety of pathogens, bacteria, viruses, or parasites. We're looking at food poisoning a lot of times. The remaining cases are caused by medications, which can be osmotically active, stimulate intestinal secretions, or damage the intestinal epithelium and cause inflammation and malabsorption or maldigestion. Chronic diarrhea lasts for more than 4 weeks and often 8 weeks or longer, which is really sad. This can be classified as inflammatory and non-inflammatory and is further characterized by the volume and appearance of the stool. And you have table 15.3 in your textbook that shows you the differences. Chronic bloody diarrhea is often caused by inflammatory bowel disease, such as ulcerative colitis or Crohn's disease. These are both autoimmune diseases. Whereas other inflammatory conditions such as celiac disease, celiac sprue, tropical sprue, and microscopic colitis is typically present with chronic watery diarrhea. This flowchart is present on page 327 in your textbook, and in the laboratory we love flowcharts because if this then that, if this then that. And so based on results or the symptoms and signs, you can determine what testing needs to be done, and based on that testing come to a diagnosis. Steatorrhea is defined as passing fecal fat greater than 7 grams per day. And this is a common feature of malabsorption syndromes. You're not absorbing the fats back through the digestive tract as you should. This fat originates from several sources: the diet, gastrointestinal secretions, bacterial byproducts of metabolism, and soft intestinal epithelium. The amount of dietary fat ingested has a minor effect on the total quantity of fecal lipids or fecal fats. In steatorrhea, the feces are pale, greasy, spongy, or pasty, and very foul-smelling. It's important to differentiate steatorrhea from diarrhea, but both can occur together. A good patient history is valuable, and this can reveal significant information to aid in the diagnosis. For example, travel outside the country, exposure to contaminated water, ingestion of certain herbs, eating fresh oysters. Proper specimen collection is crucial for accurate laboratory tests, and patient education is the most critical part. Patients don't like to do this. They don't like to collect their own poop. That's why there's usually a high non-compliance rate of about 50 to 90%. So if you're involved in this and giving the patient instructions, you want to make sure your instructions are very clear and state how important these results are for their doctor to figure out what's wrong with them. You want to give both verbal and written. So you go to the doctor and the doctor's telling you all this stuff, and then maybe there's somebody else telling you all this stuff, and then you, the lab person, is telling them all this stuff. They're not going to remember. So it's really crucial not only to give verbal instruction, but well-written instructions. And this will increase patient compliance. The container needs to be clean, sealable, leak-proof, very important, of an appropriate size. Sometimes we just want one fecal sample from one day, sometimes a collection over 3 or more days. The type of amount of feces needed and dietary restrictions depend on the test ordered. Occult blood, white blood cells, or qualitative fecal fat requires a small amount of feces, so just one bowel movement. Quantitative tests may require a 2 to 3 day collection. Contaminants you need to explain to the patient to avoid contamination of fecal specimens with urine, toilet tissue, or toilet paper. If you have recently collected a fecal sample, they now provide the patient with either a bucket to put over the toilet or a paper that they can defecate into that goes between the seat and the rim of the toilet. So you have to tell the patient it's really important that you don't urinate in the same container that you're collecting their stool sample. Gas formation can occur when fecal specimens ferment, because there's a lot of bacteria in there. And so you want to open closed containers of feces with disposable covering to prevent splatters from gas formation. And Texas Department of Health, our colleague told us stories. They do parasitology that, in the summertime, they always put those stools under a hood because the heat, of course, will cause fermentation to increase, and the lids could actually just blow off the top. The macroscopic examination includes the observation of the color of the fecal sample. Normal colors are brown, some shade of brown, and this occurs from the biopigments, the urobilins, that are orange-brown in color that are mixed in with the feces. Food, medicine, or blood can cause unusual colors, and we'll talk about the unusual colors on the next few slides. A pale or clay-colored stool may be due to post-hepatic obstructions, and this should make you immediately go to the doctor. Consistency and form. Normal feces is formed cylindrical masses, and you don't describe it because there are sometimes that you have to report the consistency of stool. You don't say it's a little hard turd. You have to use professional language. So we will look at form. We will look at cylindrical, watery. So descriptors like that are very professional. The consistency may be bulky due to undigested foodstuffs or increased gas, and soft stools indicate increased water content. Raising children as a medical laboratory scientist is always interesting, and I've told my children from the time they could talk to me, look at whatever comes out of your body, and if it looks different, let me look at it as well. And sure enough, my son, he was 8 or 9 years old, he comes to me and said, "Oh, Mom, my poop is green." And so we got to thinking, and I remembered the previous day. I said, "Jared, what did you eat yesterday?" "I had a whole jar full of pickles." Yes, and so the pickles turned his poop green. So sometimes there's a really logical cause, a normal cause of a change in color. So this shows you the different types of shades of poop. Brown is normal. Green, food may be moving through your large intestine too quickly, or you could have eaten a lot of green leafy veggies or something with green food coloring. Yellow, especially if it's greasy, foul-smelling, indicates excessive fats, which could be due to malabsorption like celiac disease. Black is bad. It could mean that you're bleeding internally due to ulcer or cancer. And some vitamins containing iron or bismuth subsalicylate could cause black poop too. So pay attention, especially if it's stinky, and see a doctor if you're worried. And I do want to interject one more thing about black stools. When you're bleeding from the upper GI tract, when the blood comes out in your stool, it's not going to be red. It's going to be broken down and broken down and broken down, and the color will change to black. So if you are passing black tarry stools, or you see really black tarry patches, this is an indication that you're bleeding internally and need to get to a physician. The most common cause of transfusion in most hospitalized patients is due to GI bleeding because it's hidden blood. Light-colored, white, or clay-colored, it's not what you normally see, and again, it could mean bile duct obstruction. And I had some friends whose daughter, and I can't remember the condition she was diagnosed with, but, the children get to a certain age where, they don't tell their parents if they don't know. And I forget how they found out that this was the color of her stool, but yeah, they immediately took her to the doctor. She immediately was getting treatment, but there was a potential that she was going to need a liver transplant. And blood-stained or red, this could be a symptom of cancer, but if it's in your stool, bright red blood is usually an indication of hemorrhoids, that you're straining, and the hemorrhoids break open and bleed, but you still want to go to your physician to get a determination of the cause. This is another chart that I liked, and I also wanted to say one other thing about black poop. One of the burger companies, I can't remember which one, but they had this Halloween burger. The bun was black, and I don't know. So I had one, and guess what happened to my stool the next day? Yeah, it turned black. Continuing on with the macroscopic examination, mucus is not normally present in the feces, and the amount that is present varies. And this presence may be associated with many conditions, both benign, which are not life-threatening, they're just kind of normal, or pathological that will require some type of intervention. Odor. Normal odor comes from metabolic byproducts of the intestinal flora bacteria. If the normal flora in the intestinal tract is disrupted or a change in food occurs, a change in odor can also occur. So I want you to spend some time with this chart. It's in your textbook, and I want you, if you see on a test, to be able to give reasons for the color of stools, some words used to describe the consistency and the form, and some other types of observations that may occur in a macroscopic exam. We're going to now talk about a qualitative microscopic exam. Qualitative means it's present or not. We don't quantitate it. So qualitative examination is important in differentiating diarrhea, or the different diarrheas, or to screen for steatorrhea. White blood cells, they're not normally present in the stool, and even a small number indicates invasive or inflammatory conditions of the intestinal wall. So this would indicate additional testing for the patient. Qualitative fecal fat, this can be seen macroscopically and then confirmed microscopically and chemically. In a qualitative test, there's a 2-slide procedure in which orange-red staining of neutral fats with either Sudan 3, Sudan 4, or oil red O is done, and a normal amount is less than 60 globules per high-powered field. Then a second slide is done to estimate the total fat. So in this case, the stool is acidified and heated before staining, and the fatty acids and salts are observed as orange to red staining globules, and there needs to be fewer than 200. If either of these are increased, it may indicate steatorrhea. Meat fibers, they can be seen on fecal fat slides, and an increased amount of meat fibers is abnormal, meaning you're not totally digesting your food. On the left, we have numerous globules of fat, and again, you have to count each globule, and so you'd have to focus up and down to get an accurate count. On the right is a meat fiber. These are fecal reference intervals for the physical examination, the chemical examination, and the microscopic examination. Chemical examination, one of the most popular and frequently done tests, is the test to detect fecal blood. It's used to detect occult blood, and occult blood is blood not visually apparent, but it's hidden. As I said, if you have upper GI bleeding, when you pass that stool with the blood present, it's not going to look red. And there may only be a little bit that's mixed in and that you cannot see, that there's black tarry areas. Bleeding anywhere in the GI tract can result in blood in the feces. And fecal blood is an early symptom of colorectal cancer. What happens is you get these nodules in your colon, and as they get bigger, and they may be precancerous, as the stool, especially if it's rough, passes through, then it could make those nodules bleed. So that, again, could be the first sign of cancer. Dark or black tarry stools can indicate bleeding in the upper GI tract. The most commonly used occult blood test is a commercially prepared slide system to test samples from 3 different days, and they have to be consecutive days. And there's 3 methodologies for testing. There's the guaiac-based, immunochemical, and porphyrin-based. The fecal blood test, FOBT, is the abbreviation. We're going to talk about the guaiac-based, and this is a qualitative test. It's either positive or negative. We don't know how much blood has been passed. Stool is applied to a guaiac-impregnated paper. It's a very special paper. And if blood is present, the heme portion of the hemoglobin reacts with the guaiac-impregnated paper. They form a bond. When you add hydrogen peroxide, which is the developer, it will oxidize the blood, which then produces a blue color. This is very cheap. It's relatively easy to perform. The big hang-up is the diet and certain medication restrictions for 3 days prior to this test, which are crucial to prevent false positives. You cannot eat beef because that has hemoglobin, which will give a false positive. There's certain foods that will give a false positive. You have to not take aspirin for 3 days or those types of medications because those have known to cause bleeding in the stomach. So there's a lot of diet restrictions, and this is where it's crucially important that you give the patient written and verbal instructions so that we can get an accurate test. Because what will happen if a false positive does occur, what's the next step? A colonoscopy, and those aren't cheap. So the patient is given a kit to take home, and it has little applicator sticks, the thing to put over the toilet, and they are told which side to apply the stool sample to. And it's really important, again, that these instructions are given. So they are to stick the stick into 2 different areas of the stool. They're supposed to look for black, tarry areas or even bright red blood if it's present. And then the developer is added. If a blue color develops on either or both sides of the slide, it is a positive test. It has built-in controls, which you must evaluate as well, because if the controls don't work, the test is invalid. So the positive side should have blue, the negative side should be clear. So if those do not work, then the test is invalid. I like to give my students on their exam, I'll have a slide that one side is positive and one side is negative. And you wouldn't believe the number of times a student will interpret that as negative. And then we talk. The fecal immunochemical test, or the FIT test, has really gained in popularity in recent years. And that's because it has 2 advantages over the traditional guaiac-based. And this includes the immunochemical test has no dietary restrictions prior to testing. This test specifically detects human hemoglobin. So if you've eaten beef or lamb or any other animal with blood, that hemoglobin is different from human and will not give a false positive. The guaiac test lacks sensitivity and specificity, whereas the immunochemical test is specific for human hemoglobin. This test uses a qualitative sandwich dye conjugate immunoassay to selectively identify the globulin component of human hemoglobin in fecal specimens. The immunoassay uses a combination of monoclonal and polyclonal antibodies, and it utilizes an immunochemical chromatographic method for detection and has a high degree of analytical sensitivity. The only limitation, or one of the limitations, is that the sample needs to be collected either 3 days prior to a menstrual cycle or 3 days after the menstrual period. So the patient is given the kit to take home, and they write their name and their information, and then they twist off the cap, and they will poke the little stick, and it has little swirls at the end to capture fecal material, and they do it 2 to 3 times in different areas of the feces. Then they put it back in the container that has a solution, and they shake it very well. Then they take it to their doctor's office for testing. In the doctor's office, we have these little icons that we will apply the sample to. Where it says S is where you apply the sample. And just like any other immunoassay, if blood is present, the line is impregnated with antibodies to the human hemoglobin. And if it's present, it will capture it. This area then has an anti-antibody that is labeled, that will attach to the hemoglobin that's attached to the other antibody. We have a sandwich technique. And so a colored line is positive, no line is negative. It has built-in controls. The background is your negative control per se. It should be very clear or white, not so pink that you cannot read the results. The control line is your positive control. If the control line doesn't work, then the test is invalid. And the most common cause is if you see you're applying the test sample down here, if you don't apply enough, there's not enough fluid to migrate forward, and you'll get a false negative. So this is a picture of an invalid test. The porphyrin-based test is one that I don't have experience with, but this assay is based on the chemical conversion of non-fluorescing heme to fluorescing porphyrins. This test enables the detection and quantitation. You can actually measure the amount of the total amount of hemoglobin in the feces and the portion that exists as intact hemoglobin, as well as the portion that has been converted to porphyrins in the intestine. The brand name is called the HemoQuant test, and it measures only heme and heme-derived porphyrins, so it's not affected by many factors that interfere with other fecal occult blood tests. I want you to know the advantages and disadvantages as well as principle of each of the fecal occult blood tests, and this table is found in your textbook. The last test we're going to talk about is the APT test for fetal hemoglobin. And it's called the alkali denaturation test, but it also may be known as the A test or the APT test. And I looked and could not find what APT stood for. This is used to differentiate between fetal and maternal blood in a newborn's stool. The blood may have come from the GI tract of the neonate or could be maternal blood ingested during delivery. So it's very important to differentiate the two. It's a qualitative test based on alkaline resistance of fetal hemoglobin. The specimen must contain fresh red blood for testing, and dilute sodium hydroxide will degrade maternal but not fetal hemoglobin. And this is the basis of a test that we're going to talk about in blood bank, that these fetal cells are resistant to degradation with a dilute sodium hydroxide. So the maternal blood will be degraded, but the fetal hemoglobin will be intact, and then you do a process to measure it or detect it. Quantitative fecal fat. This is definitive test for steatorrhea. It confirms that abnormal quantities of dietary lipids are being eliminated. It does not identify the cause for the increased excretion. Feces is collected for 2 to 3 days, so you need to have a big container. And the patient is told to limit their intake of fats, laxatives, fat substitutes, or fat-blocking nutritional supplements. The fat is measured on a well-mixed aliquot by gravimetric, titrometric, or nuclear magnetic resonance spectroscopy, and then the fecal fat is reported out as grams of fat per day, with the normal value in adults being 2 to 7 grams per day. Fecal carbohydrates. When the enzymes disaccharidase necessary for conversion of disaccharides into monosaccharides in the small intestine are insufficient or lacking, the disaccharides are not absorbed and passed into the large intestine. Because these unhydrolyzed disaccharides are osmotically active, they cause large amounts of water to be retained in the intestinal lumen, and this results in osmotic diarrhea. The undigested carbohydrates in stool results in bloating, flatulence, and explosive diarrhea due to the fermentation by normal flora. The stool will be acid, pH 5 to 6, whereas normal pH of feces is greater than 7. The Clinitest tablets based on the copper reduction principle can detect reducing sugars and other reducing substances except for sucrose. Sucrose is not detected. So this is the end. And as usual, read your textbook. It does a pretty good job with the material in this chapter. And focus on your objectives when